I want to welcome you to the Dudley Allen Sargent Annual Lecture. This is the 9th lecture. I'm Gloria Waters, the Dean of Sargent College. This is a lecture that was started in 1999 in order to celebrate the 70th anniversary of Sargent College joining Boston University. And each year we have a distinguished lecturer who comes and talks about some aspect of health. And we're particularly honored to have Dr. Kim join us this year as the distinguished lecturer. I know that our students in particular and many students across the campus have been really looking forward to his lecture with great anticipation. This year we have revised our freshman seminar, and one of the books that the freshmen have read is Tracy Kidder's book, Mountains Beyond Mountains, which describes Dr. Kim's pioneering work with partners in health. And all of the faculty who are the leaders of those seminars have told me that the students have been really enthralled with reading this book, and that it's been really inspirational to them and a wonderful way for them to start their venture of their education and trying to figure out what aspect of health they're interested in being involved in. So we really want to thank especially Jen Puccetti, who was formerly of Boston University and who's now working with Partners in Health for helping us organize the logistics of this seminar this afternoon. So Dr. Kim trained as both a physician and also as a medical anthropologist at Harvard University, where he received both an MD and a PhD. And he has 20 years of experience in improving health in developing countries. He was the director of the World Health Organization's HIV/AIDS department, and he's an expert on tuberculosis. He's received, as you know, many awards, including a MacArthur Genius Award, and he's been named one of America's best 25 leaders and one of the 100 most influential people in the world. He's currently the François-Xavier Bagud Professor of Health and Human Rights at the Harvard School of Public Health and a Professor of Medicine and Social Medicine at Harvard Medical School. And it's just a delight to have him here today. I have to say this is absolutely the best turnout that we've had for one of these lectures. So thank you very much for coming.
Thanks, everybody. Can everybody hear me? I hope everyone can hear me in the other room as well. It's really a thrill to be here. I've been crossing the BU Bridge and hanging out at BU for most of the last 25 years in bits and pieces. And it's the first time I've lectured here, so really great to see you all. So I'm going to tell you a couple of stories about some of the work that we've done, and then try to think with you through how we can take the next step in global health. There's a tremendous amount of interest in global health, but I think that it's both a time of the greatest opportunity that I can remember in my 20 or 25 years of working in the field, but also a critical time, especially for educational institutions, to step up to the challenges that we're facing. So let me start with a story about a place in Peru. This is Caraballo, and it's from a Boston perspective, it's a very poor place, but it's in fact not by any stretch of the imagination, the poorest place that we've worked at Partners in Health. And there are a lot of clues here. There's lights. You can see that there's electrical lines. And about half the people in even this community have access to water inside the home and also electricity, which puts it really smack in the middle of the countries we work in. And yet, you can tell it's a very poor area. These folks, most of them are political refugees. The war between a group called Sendero Luminoso, the Shining Path, and the government raged on during the 80s and 90s. And during that time, a lot of people came to the cities. And so this community is on the very northern tip of Lima, Peru. And this community of squatters is about 100,000 people. Lima is now a huge city of about 8 to 10 million people. And we were invited there by a Catholic priest from Boston, formerly a priest of St. Mary of the Angels, who asked us to come in and see if we could do something in this kind of very poor urban area. We had, prior to that, only worked in rural areas. And we found people like this woman. She was suffering from tuberculosis, and she'd had tuberculosis for a very long time. She'd been treated 2, 3, 4, 5 times and wasn't getting any better, was clearly losing a lot of weight. And when we met her, we just knew that she'd probably had a resistant form of tuberculosis, meaning her particular bug, the tuberculosis bug that was most prevalent in her body, had probably developed resistance to the antibiotics that were in use in Peru. And so we had to figure out whether this was the case or not, and we didn't know. So going to Peru from Boston, the easiest way is to go from Peru to Miami and Miami straight to Lima. And so we sort of looked around at the airport in Miami, and there was signs that said that you can't bring food and you can't bring animal products, but there's nothing there that said you can't bring sputum. So we actually collected the sputum of her and a lot of other people and brought it to Massachusetts and took it to the Massachusetts State Laboratory, where they found out that it was drug-resistant TB. And I'll never forget the day that we got the call when the first patient's sputum came back. It takes about 2 months to, first of all, grow the sputum into a culture and then to do drug sensitivity testing. And we got this frightened phone call from the Mass State Lab saying, who is this person? He said resistance to 5 drugs, put him in isolation right away. And of course, it was one of our Peruvian patients. And so we realized that if we were going to make any headway, and especially since in this particular community there were a lot of these people, we found 50 within about 6 months of people who had been treated in the Peruvian National TB program, which was one of the best in the world, and had continued to be sick and were not getting better despite really what should have been effective treatment. So we went to the Peruvian authorities and we went to the World Health Organization and said, we've got to treat these people. And here's what they said. Official policy of WHO was that in developing countries, people with MDR-TB, multi-drug-resistant TB, die because effective treatment is impossible in poor countries, meaning that it's so complicated that even if you had the money, you couldn't do it. So the actual doing of it was disputed. It's also too expensive, and it turned out that right about at that time, the cost of a full treatment course for drug-resistant TB was about $25,000. Now compare that to what's actually spent on health in most developing countries. And in the poorest African countries, they spend as little as $2 to $3 per person per year on health care. Peru was a little bit higher. They were around $30 to $50 per person per year. So you can imagine spending $25,000 on one person seemed crazy. So they said it was impossible. And even if it was possible, they said that it cost too much, and even worse, that it would detract attention and resources from treating drug-susceptible disease. So we started treating people. And what we did was we actually started borrowing the drugs, a creative use of the term borrowing. We actually ran a tab at Brigham and Women's Hospital. And we got to be very friendly with the pharmacy people. A couple of them were Catholic and knew this priest in Peru, and we'd go down and say, do you have any of this? And they say, sure, and they'd put it all together and pack it up for us. And they said, well, what's the account number? So, well, we literally asked them if they could run a tab, and they did. And one day the president of the hospital called our donors and say, hey, these two guys have a tab of $96,000. Who's going to pay it? We actually had hoped that the Brigham would pay it. They didn't, and some of our donors paid it. But it got us started. I remember 2 of the drugs from Lilly and Company, caprimycin and cycloserine, we actually just couldn't find it. We borrowed some from the New Mexico Health Authority. We borrowed some from the New York City Health Authority. Because what we had to do was we had to disprove that first statement. We had to show that it could be done. And we literally did it just like this, in people's homes with trained community health workers. This is Nalda. Nalda is now a hairdresser, but at the time she was a recent high school grad, and we taught her how to give injections of caprimycin to these patients. And most importantly, instead of just saying it was impossible and instead of backing off and saying it's too difficult, we jumped right in and we said, we've got to figure out a way to do this because there are lots of patients in the world with this problem, and even if it's not going to be cost-effective in the traditional sense, somebody's got to do something about drug-resistant TB. If you don't treat tuberculosis, what happens is people spread it to others. The only way to prevent tuberculosis is treat the people who who are sick with it. So we knew that this was not an isolated problem. We knew we had been hearing stories about Russia. We'd been hearing stories about South Africa. We knew that this was happening, but the approach at the time was to say, because it's not cost effective and because it's so difficult, don't do it at all. We had good outcomes. In the first in the first 45 patients, we had over an 85% cure rate. And in 1998, at the American Academy of Arts and Sciences in Cambridge, we had a meeting and we showed our data to the global tuberculosis community for the first time. And they were literally blown away. They'd never seen those kind of cure rates before. And they had all kinds of saying, well, how could you possibly have those kind of cure rates? But then when we showed the dosages that we used of the medicines and how intensively we followed the patients up, these medicines for drug-resistant TB are not like new medicines that are even better. They're old medicines. The reason they're not used anymore is because they're less effective and more toxic. We haven't had a new tuberculosis drug for over 30 years, and the reason is because only poor people get tuberculosis. Rich people get HIV, so we've got a lot of new HIV drugs. Rich people generally don't get tuberculosis, so we don't have any new drugs. So we were using these older, more toxic drugs in very high doses, and we were simply getting people through the treatment by treating the side effects. The top clinicians in drug-resistant TB in the world were blown away, and when they came down and actually saw what we were doing, they at least acknowledged the fact that you can do it. All right, so we won that battle. But the next battle is the price of the drugs. I asked people who were saying you can't do it, the drugs are too expensive. Some of them in some of the most well-known international organizations, I said, well, do you know that these drugs are all generic? And they said, what does that mean? Literally. So they had declared a death sentence on every poor person in the world with drug-resistant TB, and they did not know that the drugs that were quote-unquote too expensive were all generic. In other words, their patents had run out a long time ago. And they could be gotten for a much lower price if we just organized ourselves. So this is a very important lesson, that poor people have a lot of things done to them without thinking very hard, and because they don't have a voice to shout back, what if your parents from this room had a death sentence declared on them? Would you allow someone to declare that death sentence without even checking whether the drugs would be available in generic form or not? That's what was happening. So what we did was we began working very closely with the World Health Organization. We formed a committee. Médecins Sans Frontières, MSF, put up $1 million up front to purchase these drugs. And in a period of about a year, the prices dropped anywhere from 84 to 98%. It was still expensive, but going from $25,000 per person to a year to about $1,500 made all the difference in the world. It at least began, we began to think that this was going to be doable and that people would be treated. So from here, right here in 2000, and we started treating in 96, there's literally one country in the world treating drug-resistant TB, poor country in the world treating drug-resistant TB at high levels, and now we're up at, it's even more than that, it's about 40 countries. But we're only treating about 30,000 people in the world, about at least 500,000 people need treatment, and of those 30,000 people who are getting treated, about half of them are still being treated in Peru in our program. So we've still got a major problem, and later I'll explain to you just how bad the problem of drug-resistant TB really is. This is a graph that every student in the world should understand at some point. This is the loss in life expectancy in some African countries because of HIV/AIDS. The president of Botswana at one point said, "I fear that we in Botswana will become extinct because of this virus." That was repeated to me by the Minister of Health of Lesotho. Botswana is close to 40%. In Botswana, close to 40% of the adults live with HIV. In Lesotho, where we work, between 25 and 28% of all the adults are living with HIV. This is an utter disaster. When you have a third of the people, of the adults in your country, at risk of dying quickly of what until very recently had been a uniformly fatal disease in these countries, it affects your culture, your social structure in ways that are simply unimaginable. The only growth industry in Lesotho is the funeral industry. In the United States, the response to HIV is one of the most important, most significant social events, social phenomena that I can imagine. You know, these two people, Paul Volberding and I'm blocking, Peggy Fisher, these are great people. These are AIDS researchers who are totally committed to finding a cure for AIDS, but the activists didn't think they were moving fast enough, so at meetings they would throw blood on them. It's not really blood, it's some paint or something. But these activists would take off their clothes, they would throw blood on NIH, National Institute of Health scientists, they would chain themselves to the White House. These were people in the ACT UP movement who literally had nothing to lose and brought about the most extraordinary changes that you can imagine. Now, I know just about all of them now, you know, having worked with them very closely for the last 10 or 15 years, and it's not as if there are thousands of them. There are like 10 or 15 of them who've done most of this work. And you know who they are: Eric Sawyer, Greg Gonzalez, Mark Harrington, a small group of people, at times who brought together lots of other people, but a small group of people who did things like force the National Institute of Health to put a lot more money into AIDS research. You'll have to remember at that time it was the 4-H Club, Haitians, homosexuals, heroin addicts, and hemophiliacs. So, you know, a lot of the people in the United States were saying, well, this is a disease of a very small minority of people. Why should we put money into it? But they forced the NIH to invest, and they invested extraordinarily well. They forced the Food and Drug Administration to change the way it approves drugs, and it sped up the process really dramatically. And by 1996, we were living in a different time. The advent of highly active antiretroviral therapy turned what was before an almost uniform death sentence into a chronic treatable disease. But in 2000, at the biannual AIDS meeting, there's a huge phenomenon, which is the International AIDS Society meetings every 2 years, which is one of the most interesting meetings that you'll ever go to. 20,000 people, one group of nerdy scientists talking to each other, another group of activists taking their clothes off all the time. It's a great meeting. It's a lot of fun. But at that meeting in 2000, 4 years after it was clear that highly active antiretroviral therapy was going to transform the lives of people living with HIV/AIDS, the conclusion of that meeting still was that for now, emphasis must be placed on preventing sexual transmission because, once again, one, it's too complicated. It's too hard. We can't do it. It's too difficult. And two, it costs too much. Right? So those are the two main things that were holding us back. So those same activists, and again, I think this is going to go down in history as one of the greatest acts of human solidarity that we know of. Those same activists, mostly gay white men, said that, look, we put our lives on the line by volunteering for the clinical trials for these medicines, and damned if we're going to let only rich people in rich countries have access to them. So they changed their emphasis. And it was Greg and Mark who really were leaders, but Eric Sawyer and others as well. They said, we are going to now focus all of our energy on ensuring that every person on the face of the earth who needs these medicines will get access to them. And organizations in the South also sprung up. Zaki Ahmed, another good friend and one of my heroes, was an activist in South Africa who had access to antiretrovirals but refused to take them, and he almost died. He refused to take them until everyone in South Africa had access. And his act of bravery and courage really did push the South African government, not far enough, but at least far enough to begin talking about access to medicines. In 1998, so long before the Durban meeting, and very soon after antiretroviral therapy came to, soon after it was clear how effective these medicines were, we started a program in Haiti called the HIV Equity Initiative. This is Joseph June. Joseph June, I would argue, is the most famous AIDS patient in the world. He was one of our patients in Haiti, and we met him when his mother brought him to us, suffering from both tuberculosis and HIV. And she came to see us because she wanted money for his coffin. Surely, she thought, he would die soon. Within 3 months of receiving both antiretroviral medications and tuberculosis medicines, he looked like this. So when I went to WHO, the deal I made with the Director General was that I wanted to do something about HIV. And so I put Joseph June's picture on every document that went out of WHO. First of all, it was in the World Health Report, which is the annual report of the World Health Organization. And then every document we send out from the HIV/AIDS department had his picture. At the last AIDS Society meeting in Toronto, one of our team walked by a poster from Kenya, and there was Joseph Jun's picture. And so our Haiti staff went up and said, hey, that's Joseph Jun, he's from Haiti. He goes, no, he's from Kenya, he's from Eldoret, he's on these medicines. They knew his name. And they said, no, he's really from Haiti. And they said, no, he's from Kenya, we know where he lives. And so we had actually brought Joseph Jun to the meeting to give a talk. And so we brought Joseph Jun to the poster, and they were surprised, they hugged each other, they took pictures together. The thing is, while we'd like to think that decisions like whether to treat patients or not treat patients are based on deep analysis, on a depth of moral, spiritual, even economic, financial reckoning that leads to the most rational possible decision, it doesn't exactly happen that way. We knew that this picture was important. We knew that it was important to give people a sense of what could be done. In fact, President Bush and his people before PEPFAR saw these pictures. And we were told that it had a bit of an impact on what they felt they could do in the President's emergency plan. It definitely had an effect in Africa. Joseph Jun became Kenyan. He became Basutu. He became Botswana. People began to think of the situation they were in very differently when they saw these before and after pictures. The point being sensationalist and making up lies is not good. But if you're working on behalf of the poor, you've got to be a very good and skilled advocate. You've got to know how to use pictures. You've got to know how to use stories. Because just like the death sentence that was put on the MDR-TB patients, that stuff happens every day to poor people unless, in solidarity with them, we think hard about how we do our advocacy. So this was a really monumental day, January 28th, 2003. He said AIDS can be prevented. Antiretroviral drugs can extend life for many years. And the cost of those drugs has dropped from $12,000 a year to under $300 a year. When we saw this, we just about had a convulsion, because that was a generic price. And we were thinking, oh my God, is President Bush saying that he's going to buy generic drugs for poor patients? Well, they took that back very quickly. But this was so important. And it was important not only because we were going to treat HIV patients, but what we knew all along was it's the first time that the most powerful person in the world had committed to chronic care for chronic intervention in a poor country. We'd committed to vaccines. We'd committed to TB care, which is relatively short-term, 6 months. We'd never committed to lifelong therapy for some of the poorest people in the world. We knew that that's what we needed to do. If they'd committed to diabetes or to hypertension, it might have been as good. That's what we were trying to do. It wasn't just about treatment versus everything else. We wanted to get powerful people to commit to chronic care because, frankly, what everyone in the world needs is comprehensive, high-quality primary health care. Now, that was a great speech. It wasn't completely great. He also said the British government has learned that Saddam Hussein recently sought significant quantities of uranium from Africa, and it started a whole other process going. But on that very day, at 4 o'clock in the morning, after I had run his campaign, at least outside of Korea, I had run his campaign to be the next Director General, Jong-Uk Lee called me at 4 o'clock in the morning on January 28th of that very same day to tell me that he'd been elected Director General. And he asked me to come to WHO and, quote unquote, run WHO with him. So I told him that if I were to go, I was going to work on HIV, and I was going to try to push this particular advocacy agenda, not because we care about HIV treatment any more than we care about any other problem, but because the opportunity to get this much money moving for chronic intervention would open up so many other possibilities. So we did what's, I think, widely known in the HIV world as absolutely the craziest intervention that anyone had seen. We embraced a target. Gro Harlem Brundtland, the Director General before Dr. Lee, had said, well, we should probably get some people on treatment, and maybe 3 million by 2005 would be a good thing. And this was in 2002 that she'd made that statement. But then immediately afterwards announced that she was stepping down, and so there really wasn't very much done to try to reach the target. So we had a choice. We either embrace the target and go all out and try to get this message out, or we back off from a target as the first thing that Dr. Lee would do in coming into WHO. So I argued very hard. He talked to a lot of different people, and he came through. Because here's what he said. He had been the head of vaccines, and he remembered that when Jim Grant and Hofmann Mahler had committed to a concrete target, that they were going to get to 80% of all the children in the world that would be vaccinated with 6 of the most important vaccines, that when they set that concrete target and started moving, everything changed in the vaccine world. So he understood in his gut the importance of having a concrete target with a concrete end date. So he agreed to go ahead and do this. How did we do? Well, we didn't reach 3 million. We'll reach 3 million in about the middle of 2008. So we would have missed the target by about 2.5 years, which I think is as good as the WHO has ever done on reaching a target. But we didn't reach it. I had to swallow a lot of humble pie. I had to go and I had to apologize and tell people that we're not going to make it, and we failed, and that take the heat for that. But boy, it really got things moving. And I just don't know of any chronic intervention, complicated intervention that's been scaled up so quickly in an African setting. But again, just getting pills into people's mouth was never our goal. Let me put it to you that way. Many of us who are pushing the HIV treatment movement, the goal was not just getting pills in people's mouths. It was much broader. So by the summer of 2005, at the G8 summit at Glen Eagles, those guys took it a step further and said, not just 3x5, the target's going to be universal access, or as close as possible to universal access by 2010. That target actually came from a bunch of activists in London. And they called me one day and said, well, what's the next target? And I said, after 3x5, the target should be universal access. And they said, well, what's the end date? I was like, I don't know. I mean, I don't know if you should set another end date. It's going to take a while for that to happen. And they just arbitrarily decided it was going to be 2010 and literally forced the Labour Party to accept that target. And then the Labour Party had to take it to the Glen Eagles Summit and convince the others. So at that time, I thought, okay, I came here. I frankly, and I don't want to offend any Swiss people here, but I just couldn't stand Geneva. The worst part of Geneva is that the Chinese and Korean food are so expensive and so bad. And as an anthropologist, I've come to the conclusion that the quality of Chinese food is actually a very good indicator of the relative dynamism of an economy. Dynamic economies have Chinese people, and when they go, they have good food. But I realized at that time that I could come back. By the way, I live right next to Chinatown now. We decided to move to an urban area. I decided I could come back to Boston. And boy, was it a good time to come back. Just as an aside, isn't it amazing how sports has changed in Boston? I'm a big sports fan. So I came back to Boston, and the question for me was, now that we've made all these advances, now that we've made so much progress in really convincing former skeptics that we have to do something really significant. We have to not only treat HIV, but we have to treat TB, and we have to treat malaria. And oh my gosh, if they're going to do all that with HIV, we better do something about maternal mortality. Women should not die in childbirth. Pregnancy should not be a risk factor for death anywhere in the world. So everybody started thinking bigger, and I knew that we had to figure out some way to capture these gains and turn it into an operational system that would build what we needed. In Haiti, we'd always done this. When we got money from the Global Fund to Fight HTB and Malaria, another new and very important funding organization, we said to them, you can't just put pills in people's mouth. You have to build primary care. So we convinced them that some of the money should be used for basic medicines, for health workers, especially community health workers. And in 3 months, by March of 2003, the clinic looked like this. And it was empty, and people said, well, people would make all kinds of conclusions about, well, poor people just don't trust the healthcare system. These Haitians don't understand about Western medicine. Look, it was very simple and straightforward. They would go there, but there would never be anything there. And the doctors would, the government would pretend to pay the doctors, and the doctors would pretend to show up. There wasn't any seriousness about making sure that the clinic worked. So we made the clinics function, and of course people showed up. And it also destigmatized HIV. If the only thing that you're doing in a place is giving out antiretroviral medicines, you're going to have a hard time getting people to come in. But if you have an overall health service that's providing a range of services, HIV can just be one of them. The way we do it is we talk about 4 pillars. Any HIV program has to have HIV prevention and care, has to have a good TB program, has to have women's health, including reproductive health, family planning, and PMTCT as prevention of mother-to-child transmission of HIV. But it also has to be detection and treatment of sexually transmitted infections. That's what we always start with. But we soon move from there to providing surgical services because women shouldn't die in childbirth. And we've had surgeons so far, but there's a lot of very interesting programs in Mozambique and elsewhere where they've trained clinical officers with 2 years of training to do cesarean sections, and they've done very, very well. So our purpose has been, look, people don't come to you and say, hey, I've come here because I just have HIV. And if you just give me the antiretrovirals, I'll be fine. They come to you with a whole range of problems that they don't know how to identify themselves: hunger, poverty, lack of employment, lack of education or access to education, no housing. And so in all of our projects, we've tried to address all of these needs, not necessarily because it is exactly the model that can work everywhere in Haiti today, but that we firmly believe that's what we should shoot for and that we can afford it. So we actually did a costing study in Rwanda, and our comprehensive intervention in Rwanda costs about $25 per person per year. Now that's more. As I said, sometimes in Africa it's as low as $2 or $3 per person per year. It's more, but it's just so affordable. I mean, compared to what we spend, $6,000 to $7,000 per person per year. Our conviction is that, once again, $25, $30, $40 per person per year is a target we should all shoot for. This is certainly what Jeffrey Sachs has been arguing for years, that we can eminently afford this. And in fact, he's been arguing, I think convincingly to me, that we can't afford not to do it. Lesotho is one of the other countries in work. And I just show you this country to tell you just how difficult it's going to be. So Lesotho is a country of 2.2 million people, entirely encased within South Africa. The numbers in Lesotho are staggering and horrific. They've lost 20 years of life expectancy, 20 years or so of life expectancy in the last 15 years because of HIV. They're right next to KwaZulu-Natal, which has the worst reported epidemic of drug-resistant TB, and I'll show you a little bit more data very soon. And the people who do the most difficult jobs in the mines are said to be from Lesotho. So there's cross-border spread. There's cross-border movement and cross-border spread, of course, of the diseases. So a clinic very close to the border, very close to Lesotho, and not right on the border, but close to Lesotho, they started noticing that there were a group of patients that were dying very quickly, and they were dying of tuberculosis and HIV. Now, some of the data, the most important thing is look at here. So of the 53 patients they identified with extensively drug-resistant TB, which is not only multi-drug-resistant TB, but TB that's resistant even to the second-line drugs, 52 of the 53 died in that study. And the average length of time it took from diagnosis of TB to death was 16 days. So HIV knocks out exactly that part of the immune system that keeps tuberculosis in check. And so what happens is these drug-resistant forms are spreading very, very quickly. And that sounded to us like a match going off. And it turned out that when they did the genetic typing, it turned out that 26 didn't have any access, it had not had previous treatment. So that meant that if they hadn't developed the drug-resistant TB on their own, they probably caught it from someone else. So when they looked at the spoligotypes, when they looked at the genetic fingerprint, 26 out of 30 were identical. So they'd given it to each other, and it turns out probably that as part of a support group, so these poor people who have two diseases are totally depressed, they did a wonderful thing. They put them together in a support group, and they spread the drug-resistant form to each other, and they died like that. Right? So it's going to be hard, and I would argue that the biggest problem in global health, the one that we have to resolve in order to take the next step, is the implementation bottleneck. We've got vaccines, we've got we've known how to do primary health care for a long time. There are these therapies out there, and we're just not getting them through. It's so exciting that there's all this new investment in global health. This doesn't even count the Warren Buffett money, which is going to be some $40 billion new dollars in addition to the money that John Cohen described in this article. The Gates Foundation is doing such great work. The tools that we have to diagnose TB, sputum smear microscopy is more than 100 years old. The drugs are old. So the Gates Foundation has really made a commitment to developing new tools. But I have a concern. There is no law of hydraulics that I know about that says if you put a new tool on top of a lot of older tools that are not being delivered, that somehow those new tools will automatically flush the other ones through the system. This is what's going to happen, I fear. We're just going to have a lot more tools that aren't getting delivered. And in fact, the net effect will be to worsen inequality, because the people who will access these new tools are travelers. The travelers will get new malaria drugs. The people with TB will get, in the United States, will get access to these new drugs. We've got to figure out a way to break through that implementation bottleneck. So in talking to a lot of different people about how to do it, I get all kinds of answers. One is markets aren't working, incentives are misaligned, slow division of knowledge, lack of, these are all true. These are all really part of the problem. But what you often hear is, well, it's just management skills, or it's just that incentives are misaligned. It's not just anything. It's just the realization that healthcare is incredibly complicated. And frankly, we don't do it very well here in the United States. 33% more expensive than any other developed country in the world, and we're 24th or so on some really basic indicators of how we do with our healthcare system. 40 million surgeries a year. Japan does half as many and has better health outcomes. So we don't think about healthcare delivery as an exciting, important area of study, and we certainly don't have a commitment in the United States. Let me put it this way. A lot of people are trying to fix the American healthcare system. A lot of people are talking about universal access to healthcare. But I fear that it's so broken in so many different ways with so many vested interests that it's in a lot of trouble. We have a chance in some of the developing countries where not much infrastructure exists to leapfrog a whole generation of bad practice and build really great systems. The person at Harvard I ended up working with most closely is Michael Porter from the business school, because Mike Porter is an expert in strategy. And he said he's actually, this is a guy who's apparently one of the most expensive consultants in the world, $125,000 a day or something like that. And Mike, I'm sorry if you see this video. I had to tell your secret. But it's because he's in huge demand, and the guy understands value like no one I've ever seen. His specialty is strategy. What they do is they start with case studies to try to figure out what's actually happening in any given industry. They do field research to figure out, so why is this particular company doing better than another, or what is really going on in this particular industry? They use quantitative and qualitative analysis, and they work really hard at developing analytic frameworks. Porter's 5 forces of strategy and competition are taught to every business school student in the world, and that's what Mike's been driving us toward. And then you really try to get at theoretical principles, look at the whole problem, and then in the end of the day, help practitioners. So in Uganda, with PEPFAR money, there are 2 programs, one run by Peter Mugenyi and one run by TASO, the AIDS service organization. TASO has motorcycle riders, community health workers, teledramas, they have singers, community-based all the way out to the household. Peter is a physician, an infectious disease physician, incredibly dedicated, and he writes prescriptions and helps people to get access to the medicines, but doesn't do any of that other follow-up that we found is so critical in the places we work. 2 very different models, coexisting in the same country, both funded by PEPFAR. And that's what's happening everywhere. Little cottage industries, everyone trying to solve problems on their own, separate from each other. Our sense is that what we've got to do is capture experience where it's working really well, where it's not working really well, and attack this problem like Mike Porter and the business folks would attack a strategy problem. There's a lot of research to do. There's operational research, there's modeling, there's even basic science research, a lot of different research that has to be done to figure out exactly how to do it. But we've also got to take that step back and look at the whole field. I have not found any current programs that teach global health delivery in that way. We teach how to do research on, say, decision analysis about whether you should use CD4 counts or not. We can teach very specific narrow tools, but teaching about the experience of delivery by the case method, for example, the way they do at the business school, is not something that I found in any of the degree programs we have, including at the business school. They don't teach them about how to deliver healthcare in Malawi. They teach them about why Intel invested in Costa Rica. we really think that there's a new place for a new, maybe it's not a discipline, maybe it's a field. Basic science has been very well developed. Clinical science, which is relatively new on the scene, evidence-based medicine is new, is now very well accepted. And evaluation science is also very well accepted. We think that there might be room for something that we're calling healthcare delivery science. The holistic but also very deep study of how you build systems that can deliver the products that we need to deliver in these developing countries. We think that information technology is going to be extraordinarily helpful in making this happen. You know, AMD Athlon, the chip maker, has just committed that they're going to wire all of Rwanda so that there's going to be Wi-Fi and WiMAX on every square foot of Rwanda in the next 2 years. If any of you have seen Nicholas Negroponte's $100 laptops, those are amazing. I just saw one recently. They are amazing. And we think that if we put some of these lessons that we're learning through our study of global health delivery online, that not only can it provide a model for people out there actually doing the work, but that if we can get them hooked up in social networks, that they can mentor each other in a way that we could never mentor them ourselves. I mean, to sort of understand how this works now, I was in at the University of Washington, and I was giving a talk, and a young woman, a student, came up and said, will you be my friend on Facebook? And I thought, you know, is she propositioning? What's she telling me? And so I'm now on Facebook, and it's not quite right for developing countries. So the guy who started, he started 5 companies, and his latest one, he's in Boston, a good friend of mine. Latest company is a travel website called kayak.com. He owns it. He now works with me 2 days a week to try to figure out a way of bringing the absolute clearest, easiest to use user interface so that we can create communities of practice that will take the insights and then spread them to everywhere in the world. So that's what we're doing. But let me just end with a couple of quick observations. We're trying to do all these things. We're trying to build this field. We're doing it with Mike Porter. We're doing it with folks at the School of Public Health. You know, there are not very many practitioners of global health in the School of Public Health, but the ones that are there, we're working with them. And we'd like to do it with you. This has got to be a project that we all share. We can't write all the cases. There's so many things that all of you know that are doing work in global health, and it's got to be a multi-university process. We need to do this as a consortium of universities and not as a single program. But there's still a problem. As recently as 2006, my good friend and colleague David Canning from the School of Public Health said, you know, it's too much, guys. You know, there's just not enough money to go around, and if, you know, we're going to have to make choices. And so, you know, international institutions should focus their health spending first on the prevention of HIV transmission before moving on to treatment. But, you know, advocacy works in a lot of different ways. The Gravina Access Project was introduced to connect Gravina Island, population of 50, to the megalopolis of Ketchikan, population 8,000, by a bridge. And this was advocated by a senator and a representative from Alaska. That died eventually in September 21st. But this bridge had some very powerful advocates, and we almost got to the point of spending $400 million on a bridge that even these folks didn't really want, if you ask them. Who is going to advocate for Jimena? Jimena is from Peru. She was suffering from both HIV and TB, and her mother came to a clinic, really again asking for money for her burial. We picked her up. We began visiting her every day. She's got treatment for both her tuberculosis and HIV, and now she looks like this. The war in Iraq. This year, $196.4 billion extra dollars, and this has its advocates as well. I'm not making any judgments on whether these are good or not. You might be able to tell how I feel about it. But the point is that advocacy can bear some pretty extraordinary fruit. Now, this is on top of the $524 billion that we're already spending on defense. What about Jean-Luc? Jean-Luc is one of our patients from Haiti. He came in suffering from that age-old scourge, malnutrition. And so with high-tech delivery of food, he looked like this. What about the corn industry? Corn subsidies were started as a temporary emergency measure during the Great Depression. They've received $51 billion in subsidies over the past 10 years. I grew up in Iowa. I think corn's a good thing. I think corn farmers are good people. Good advocates can help to get some good things for that particular group of people. I think it turns out that the people who benefit most from this are large farmers. But the point is, in this government, advocacy works. Who'll advocate for this particular clinic, which we started in Rwanda? This was post-genocidal Rwanda. This is what the functioning clinic looked like when it was given to us in 2003. And this is what it looks like now. The sugar industry, on the other hand, through 3 different kinds of indirect lobbies, including import quotas. If you want to get a Cuban ministry person very angry, ask them about sugar, because they're blocked from selling sugar in the United States. But so are a lot of the other countries that grow sugarcane, because we protect the sugar industry in the United States. And it costs you guys, consumers, about $1.9 billion extra dollars a year because of the sugar prices. Again, I'm not saying anything against sugar farmers. These guys have been very effective at advocating. This is military spending. And in survey after survey over the last 20 years, this has been looked at. They ask Americans what % of the federal budget you think is spent on humanitarian aid. And they say that they probably think about 10%. Only 18% guess that it was less than 3%, and it's actually 1.6%. When asked what it should be, they say 15%. So I'm not being Pollyanna. I'm trying not to be Pollyannish and saying money will solve all the problems. But there's a tremendous opportunity to do some really great things if we continue our commitment to building those health systems that will require some money from the United States. And more than anything else, it will require your dedicated work and your advocacy. This is Jean. And this is the mission statement from Harvard Medical School: to create and nurture a community of the best people committed to leadership and relieving human suffering caused by disease. I would argue that at Harvard Medical School and everywhere else, taking on issues, unsexy issues like global health delivery, committing ourselves to the kind of advocacy that's been so effective for the corn industry and for the sugar industry, if we do it and build health systems in every single country in the world that's capable of delivering primary care, we'll see transformations like this. Jean is, in fact, we got him on an exercise program. He's got that belly back. But I hope we can do this together. I hope that we can build this field of global health delivery, and young people among you will become outstanding expert implementers who can go anywhere in the world and deliver health care. And you'll be so much better than we could ever imagine ourselves to be. I really look forward to that day when you can tell me, oh, you guys had so little vision. You know, we've done it now everywhere in the world. I look forward to it and hope I can be there with you. Thank you. So I really apologize. My own implementation skills in my son's pickup was not good, so I have to leave a little early today. But I've got a few minutes for questions, and I'll take questions from anyone. Yeah.
I am a senior here at Boston University, and I'm applying to medical school. I'm actually applying to Harvard Medical School, and this is what I want to do. What can I do to be trained in the absence of a field like the one you described?
Well, the good news is I think by the time you get to medical school, well, the first thing you have to do is really study hard and do well at BU and get into Harvard Medical School. Okay, that's the first thing you have to do. But the second thing is, you know, we've really jumped into this, and so Mike Porter is teaching us. The first thing we have to do is we have to capture experience. So we've got 11 cases already under development. We're using other cases that have already been written, and we're going to start teaching young people about global health delivery. So the first course in global health delivery will be given at the Harvard School of Public Health this winter in January. And then we'll start another much more intensive course in the fall. And the hope is that with other universities, we're going to share all of our cases, of course, and we're hoping that we can have many universities even, teaching the course together. We'll learn from each other, we'll share insights, they'll share their cases with us, and very quickly, as opposed to waiting for 20 or 30 years, in the next few years, we want to try to get that field moving. So whether you go to Harvard or elsewhere, my hope is that in the next 2 or 3 years, you'll be able to study global health delivery. Yeah.
Are partners in health doing anything to have the target communities be self-sufficient eventually, so that they're not relying on PH to provide the health care?
You know, the thing is, if you have to look at the particular country. So Rwanda's plan, and they've got a 7% growth rate. They've got a president who has an MBA, who is one of the most effective and non-corrupt politicians I've ever known in any country. Their plan is by 2010 to be fully self-sufficient in terms of healthcare expenditures. But Haiti is just, you know, I mean, frankly, Randall Robinson and others have argued, I think, very convincingly that our government actually removed President Aristide. And so many bad things have happened to that country. I don't know when Haiti will be self-sufficient. So I think in some countries, you know, if we want to be decent about it, if we want to stand in solidarity with the people, the money is going to have to come from the outside for some time. But of course, the ultimate goal is that these societies will be quote unquote, well, let me put it this way: self-sufficiency is kind of a hard thing to understand what it means, because every economy is so connected with every other economy. So what does self-sufficiency mean in the context of what happened to Rwanda at the hands of the Belgians and the French and the U.S. during the? I mean, what does that mean to be self-sufficient? I would think that there are still reparations to be paid and damage to be undone. So, ultimately, it'd be great if there were thriving economies. Even if there are thriving economies that are generating enough money, my sense is that those of us here in the first world still can help by doing things that it's difficult to do from Rwanda, no matter how wealthy they are. We can capture experience from everywhere in the world, put it together in interesting ways that can be then taught to other countries. I think we'll still have that role for some time. If eventually they're doing all that work themselves, that would be great. Then I can go and retire and play golf or something. Yeah.
In creating the field of healthcare delivery, how much do you see the field harnessing the existing business machine? You're working with Michael Porter,
yeah.
But how much of that is new and how much of that is already existing?
Well, the thing is, so we say this all the time. Well, businesses do things so well, go talk to them. So I actually have talked to a lot of businesses. And the thing about businesses is you have to be very specific about what you're asking from them. They're busy, and they're not, other than the drug industry, and the pharmaceutical industry has made huge financial and other kinds of contributions. But the other industries, it's true that you can get Coke to anywhere in the world, right? But I don't see Coca-Cola standing up and saying, and just put all your antiretrovirals in our truck and we'll deliver them, right? Because they're busy and they've got things going on. So it would be great if companies chipped in and helped us think through things like logistics and procurement and supply chain management. It would be great. Right? But I don't think that that any of us, especially who have been working in global health for a while, we can't just outsource all our work to them, because I think at some level they'll get it wrong. And let me tell you why. Because this work has to be based in solidarity and social justice. It can't be based on some sort of notion that businesses do it better, so let them do it. The only reason we're doing it is because we fought so hard for social justice and solidarity. And if we ever lose that piece of it, I think we're going to be in trouble again. Yeah. Well, no, we have to. Anyone else with another question? Yeah, go ahead.
In terms of pursuing the ultimate goal of reaching worldwide universal health care by 2010 and social treatments for HIV tuberculosis, and you mentioned earlier about the previous era of solidarity among organizations and among public providers. But from my personal experience, like seeing NGOs in international, in just different countries, there's also a sense of competition between the organizations just for grants and for money and that sort of thing. How do you propose to overcome that and really create the solidarity?
That, competition and backbiting and the explosion of what we now call suitcase NGOs, NGOs that didn't exist until 5 minutes before PEPFAR announced that they were looking for NGOs. There are a lot of them out there, there's no question about it. But I think if there's a new institute out in Seattle called the Institute for Health Metrics and Evaluation that's really trying to completely revolutionize how effectively we evaluate specific programs. So if we're better at evaluating, the metrics will be there. We'll know which NGOs are doing well and which ones are not. And I think also delivery science would have a role, because once we really look deeply into their particular delivery models and are able to say, hey, there's really something here, and in fact, it looks like some really successful what some really successful businesses have done. If we can do that, I think we can help by really putting the hot light of scrutiny on these various NGOs and being able to tell the rest of the world whether the donors are getting what they're paying for. Now, I'm not suggesting with global health delivery that this is entirely new and no one's thought of this. A lot of people have been working for a long time trying to put this together. But inside academic institutions, the study of implementation, delivery, management, it's just very difficult to get a strong foothold in schools of public health and in medical schools. That's really what we're trying to do. And we think that by bringing that sort of really hard-headed assessment of whether or not you're delivering value to these NGOs, that we'll be able to give much better information about how we should invest. Yeah, right there.
How are you delivering comprehensive and community care services in a place like the Super Rwanda, using mostly community health workers? Don't you need those doctors? And I've heard of Dr. Farmer admit that there are very few doctors. That's
a great question. If we know one thing about community health workers, we know that if you leave them alone without support of nurses and doctors, those programs fail. But we would never do that. I mean, that's never what we do. The most important thing about a community health worker is that they're out there, the eyes and ears of the existing medical system. If they have no one to refer to and they're doing things on their own, it's horrific. And I've had some experiences of going to visit standalone community health worker programs, and they themselves are totally depressed. They're saying, so, you guys came and gave me nothing, a little money and a book or two, and then designated me the community health worker. And so now people in my community actually come and ask me what to do when there are problems that I don't know, and I have no one to refer them to. That's not what we should do. What we should do is really extend the reach of nurses and doctors by connecting them to community outreach workers. That's what we've always done. Yeah, there.
Going back to what you were saying about the project in Peru with having to convince people that these sorts of treatments are possible, since you've done that sort of thing, have you found that it's gotten any easier to convince people that these sorts of problems are soluble, or do you still have to?
It's a great question. Well, if we just stayed with the same problems, yeah, I mean, so right now, the explosion of drug-resistant TB and HIV in South Africa and Southern Africa has turned everyone into a believer, all right? So the people in this community said, you guys are crazy, you're immoral, how dare you talk about drug? I mean, they were angry at us. It wasn't just that they disagreed politely. They were angry at us for even bringing it up. And now they're all converts. They say, oh, yeah, we agree. We agreed on that a long time ago, yeah. That's where they are. The problem is if we just stayed at the same level of demand, then it would be okay. But we keep making the demand bigger. So it was MDR-TB and then HIV, and now it's comprehensive primary health care for everyone on the planet. That's a pretty big, idea. And now people are saying, oh, but, that's not really possible. Well, a lot of people are on board. I mean, the Director General of the World Health Organization, who I had the great privilege of getting to know while we worked for J.W. Lee together, says that's the goal, folks, comprehensive primary care for everyone on the face of the earth, especially for women and especially in Africa. So it's not so hard to convince people. What's going to be hard is to get the delivery right? That's the really, really hard work. Looking at a program, the Bangladeshi Rural Advancement Committee, BRAC, the largest NGO in the world, the way they manage TB programs there in Bangladesh is just extraordinary. But very few people really understand what's going on, how they're doing it, how it works, and are thinking about how to take that model and apply it elsewhere. That's going to be the hard stuff. If we get that right, if we develop these communities of practice so that we're irrelevant and the Zambians and the Tanzanians are talking all the time about how to solve particular problems, then I think that the world is going to be moving in a really extraordinary direction. Maybe one more question, all the way in the back, yeah. Okay.
I noticed that you have indicated a significant collaborations with NGOs. Has there been any collaboration with governmental organizations like the Peace Corps, and what kinds of problems or what are the assets and liabilities of working with the
You know, in Haiti, it's been very difficult to work with the government, given the political problems, the U.S. government anyway. And yet, you know, our strong belief now is that you cannot do this kind of global health work and not involve the national government. Because, you know, in the end, they're the ones who are going to be there. And even through various regimes, when we've been doing really good health work, the new regimes haven't shut us down because they actually need a winning horse to be able to say, you know, we do provide some good services. So I think that I'm not sure what will happen during the election of 2008, but, you know, there will be a new president no matter what. And I think that president is going to be facing some very, very difficult problems. And one of them is how to remake America's image in the rest of the world. My own view is that if we got really good at delivery, and that when we sent you young people out there, they didn't say, oh my God, the Americans are coming again, but they said, wow, these Americans have been really trained. And they're linked to these incredible networks so that we have tremendous access to successful projects and people who are talking to each other all the time about how to make this work. I think that's a wonderful way for any new president to start out thinking about how to remake the image of our country and the rest of the world. So, you know, it's a mixed bag out there right now. I mean, there are some American-funded programs that are great. There are other American programs that are not so good. I do know, though, that we're still not where we should be in terms of a commitment to absolute professionalism and the highest quality in everything we do with our overseas dollars. And it's a good project to take on. Thank you very much, everybody.